think we'll wait just a couple more minutes as people are starting to join. I think I'll just wait until the joining curve becomes less exponential and starts to taper. Okay, well, I think maybe we should get going. Thanks everybody for joining. Welcome to today's seminar for the Learning Health System Seminar Series. The title of today's presentation is Virtual Group Visits, Implementation and Evaluation Across an Ambulatory Hospital. It's very exciting to be able today to present work that's happening in Women's College Hospital and really reflects the core work of how we're envisioning a learning health system. So I'd like to introduce today's speakers and I will hand it over to them. First is Dr. Geetha Mukerji, who is a staff endocrinologist at Women's College Hospital in the Division of Endocrinology. And she's also the Corporate Medical Information Officer, or CMIO, at Women's. She also works with the diabetes education team at Tattle Creek Family Practice in a shared care model. She has a master's degree in quality improvement and patient safety from IHPME at the University of Toronto, and she's the clinician lead in quality at Women's College Institute of Health System Solution and Virtual Care, and led several quality improvement and virtual care initiatives that promote the quintuple aim. Her academic interests include developing and evaluating novel models of ambulatory care and promoting high-value care delivery. We also have Dr. Neesha Hussain-Shamsy, who's a postdoctoral fellow at Women's Mental Health Research Program at Women's College Hospital. She received her master's in health sciences from Johns Hopkins School of Public Health in 2011 and PhD in health services research in the health informatics stream in the Institute of IHPME at the University of Toronto in 2024. She's currently postdoctoral fellow at Women's Mental Health Research Program. Her research interests include the use of virtual groups to deliver care, particularly to support delivery of perinatal mental health services. She has extensive experience in maternal and child health services research locally as well as internationally. So it's wonderful to be able to welcome both Dr. Mukerji and Dr. Hussain-Shamsy, and we all look forward to your presentation, after which people will be able to ask some questions.
Thanks, David, for that very nice introduction. We're really thrilled here, both Neesha and I, to be presenting to this group, just to highlight some of the great innovative work that we're doing locally and how that really builds upon the vision of learning health system here at Women's College Hospital. We're going to share some of the work that has been conducted across multiple clinical areas within our hospital on implementing and evaluating synchronous video conferencing groups at Women's College, and to share some lessons and hopefully to spark some discussion here within this group on building a learning health system. So in terms of our outline, we'll first talk about the context or the burning platform for the innovation, followed by implementation, discuss some of the evaluation and quality improvement findings, and then lessons learned, then tying it back to the learning health system. So in terms of group health interventions, delivering care to patients actually can happen more than one-on-one interactions with healthcare providers. Group-based health interventions such as therapy, education, and exercise interventions are an integral part of prevention, self-management, and treatment of many physical and mental illnesses. Driven in part largely by the pandemic, we transitioned from in-person group health-based interventions to video conferencing groups that were embedded within our electronic medical health system And we pivoted to institutionally embedding these synchronized video conferences groups across the hospital. This allowed us a unique opportunity to build upon the literature and evaluate the novel innovation alongside implementation. So what's the value proposition of group video conferencing? So compared to in-person groups, video conferencing offers several benefits. One is that it can be cost effective. You can reach multiple people within a same time window. It may reduce barriers to attendance for some populations, particularly people living far away, postpartum, where there are issues with childcare, patients with both disabilities in terms of pain and visible disabilities as well, and with regards to mobility. It allows them to receive group-based interventions within the comforts of their home. It can also be human resource efficient. And it can navigate issues with space constraints at the hospital level. And it can address geography apartheid. So regardless of where you live in Ontario, you can receive care within the group health interventions. And it can also free up provider time for high value in-person care. So while video conferencing group may offer improved access for our patients, it does require thorough evaluation to see if it meets the needs of our patients and care teams and is of high quality. So our goal was to understand key outcomes related to the implementation of institutionally integrated video conferencing group at Women's College Hospital and the impact of the innovation. To date, a lot of the studies have really been pilot form or very narrow to a certain condition. And we had the opportunity to test it across multiple different conditions and across multiple different clinical areas. So we'd like to start with what was the previous state. So previously with in-person groups, we had multiple group-based interventions across multiple clinical areas. It was in person and required clinical space in the hospital. We were limited by the space in some areas. And also there was a lot of variability of participation due to external factors. So weather, childcare barriers, work-related barriers really impacted the attendance. And with COVID-19, we needed to rapidly pivot to video conferencing groups and ensure that we could provide a continuity of care for our patients. So this was really the burning platform for innovation and really was the springboard for us to implement and also evaluate this novelty. So what is our innovation? So we integrated Zoom-based video conferencing with Epic and My Health Record. This allowed us to document easily within the same interface within Epic while conducting the group video visits because it was all synchronous and it was integrated. This allowed us to also create and disseminate meeting links right within Epic, and ensured secure identity verification, and allowed patients to complete pre-visit or pre-group visit My Health Record patient-administered questionnaires to fill out key clinical data for participation. Since we integrated this across the hospital, we had a unified administrative and patient workflow. Because this was a new innovation across the hospital, a group video visit subcommittee consisting of clinicians, administrative personnel, IT personnel, along with senior administrative senior leadership, led by Dr. Lori Wasserman in mental health, allowed us to look at both implementation and evaluation and allowed us to integrate quality improvement findings to improve the delivery of video-based conferencing across the hospital. And we also embedded evaluation alongside the implementation. So as a CMIO, I always want to share some of the IT enhancements that were made. So here you can see how the IT team sleekly embedded within My Health Record, the video conferencing group link. So patients received personalized My Health Record links where they had the appointment confirmation alongside the reminder on the day of the appointment. Following clicking Join Video Group Visit, next slide, you can see that the patient has a chance to start their video visit, and their brought in to fill out their, confirm their demographics, fill out any pre-visit questionnaire, and complete their e-check-in for their group video visits. This allowed us to verify identity, which was integral in terms of the security of group video visits. Next slide. And then when they join the video visit, Zoom is launched, and then they're placed in the waiting room until the facilitator can admit them into the Zoom call. Next slide. So in terms of the implementation, we needed to ensure both administrative, clinical, and patient workflow was developed alongside the IT requirements in terms of security. This is just a flow diagram. So these are the three main things that needed to be done: is scheduling the group, entering the group, and identification verification. Next slide. There was a 3-phase rollout, and the first group video visit was launched May 2020. This was 6 weeks after the pandemic hit at the hospital. So this, you can see, is quite rapid. It was iterative, and after each phase, stakeholders debriefed to determine readiness to move to the next phase of the rollout and ensure the technical workflow met the requirements from the clinical teams. Early adopter group moderators were trained as clinical champions to train their peers by phase 3. The next slide just shows the 3-phase rollout. And after each phase, there was a readiness regroup. And so after phase 1, after the development phase and go live, the readiness regroup identified that we needed to improve audio and video quality and develop further training materials for both patients and providers and facilitators. In phase 2, there was more group and moderator identification and support that was done. And prior to and after go live, we identified that we needed to enhance the clinical workflow to make it easier for scheduling and patient identity verification. And then in phase 3, clinical champions prepared other co-facilitators. We needed to augment support and training before go live. And after following this phase, we did minor format modifications, both logistical and housekeeping considerations in the first session. We also modified the clinical documentation for group video visits as well. And then we had full-scale implementation across the hospital. So in the first 6 months after launch, between May 2020 to November 2020, 29 video conferencing groups were run across 5 hospital divisions with over 767 unique patients across the hospital. This was a major feat in implementation, and our stakeholders were engaged, and our patients were excited by the ability to maintain continuity of care with the innovation. So next slide. So while we were implementing, we recognized there was a dearth in the literature on how to best evaluate virtual groups, and we realized we actually could build upon this literature, and we developed a virtual group evaluation framework. So this was Neesha's second paper as part of our PhD, and so this framework was we needed to integrate several different elements. We needed to integrate group-based intervention design and innovation approach. Implementation outcomes were measured by Proctor's evaluation framework. We also needed to look at service quality as the IOM, or the National Academy of Medicine quality domains, and then followed by the looking at the quintuple aim on outcomes and impacts. This was alongside group-based dynamics and development and looking at facilitator and participation characteristics and contextual influences. Our paper was published in 2022, and now we have the opportunity of testing that framework within our paradigms, and more broadly allows other institutions who are integrating virtual group interventions to have a framework to have some guidance on how best to evaluate. Next slide. We wanted to design our framework to be flexible to ensure that we could incorporate multi-methods of evaluation of both quantitative and also qualitative. And I'm going to turn it over to Neesha, who's going to talk through the methods of evaluating our group-based interventions here at Women's College. Go ahead, Neesha.
Thanks, Geetha. So as Geetha mentioned, we operationalized this framework using a comprehensive evaluation of video conferencing groups here at Women's College. We looked at administrative data from Epic. We conducted a cross-sectional survey of facilitators in the fall of 2001, and we conducted a pre and post group survey of patients who completed or participated in a video conferencing group in 2002. In terms of the patient surveys that we used, all patients registered to participate in a video conferencing group between July and November 2022 were sent a pre-group survey, which was embedded into their group video visit instructions, which they received prior to completing their group. They were also sent a post-group survey about 12 weeks later to accommodate the length of most video conferencing groups being run at the hospital. So the QI surveys were administered through REDCap and were optional for patients to complete. In order to deploy the post-group survey, I mentioned the pre-group survey was embedded into video group instructions. The post-group survey was slightly more complex and required a member of our team to run a list in Epic of all of those who were registered in a first instance of a video conferencing group in the 12 weeks prior. They were sent, those individuals were sent an automated message containing a link to the post-group survey in REDCap. For these reasons, we weren't able to actually link the pre and post-group survey responses, but we were able to ensure that the majority of people who were participating in a video conferencing group during that time were able to receive the opportunity to complete a survey. So in the pre-group survey, we incorporated measures that were informed by our evaluation framework, as you can see here. In our pre-group survey, we asked patients things like what their comfort with technology was like. We administered an eHealth literacy scale, which is a standardized measure of readiness to really participate in virtual care interventions. Our pre-group survey had a response rate of about 50% for a sample size of just over 1,300 patients. After the pre-group survey link went out, people participated in their video conferencing group. Our sample comprised of 36 groups over 6 care programs. And then because we were doing this real institutional level bird's eye view evaluation, with 36 groups, they're running at different lengths of time in different ways. And so by 12 weeks later, most groups had concluded. And so at that time, patients got their post-group QI survey. We administered the satisfaction with therapist and therapy scale, which is a standardized tool to measure satisfaction with group therapy. We modified the language to make it a little bit more generic to reflect that at our institution, not only were we running therapy groups virtually, we were running exercise groups, educational groups across all different domains. We also assessed whether people had practical issues with participating, whether they felt like the groups were helpful, and overall experiences and future preferences. This survey had a lower response rate of 15% for a sample size of about 400 patients from Women's College. When we look at kind of the sample of people who completed the surveys, our facilitators were very engaged in survey completion with an 83% response rate to the survey, representing a variety of primary occupations here at Women's and across the spectrum of care programs. Most people who were facilitating groups from our survey had been in practice for over 10 years. For our patient sample, we did ask sociodemographic information during both survey time points because we knew that we weren't able to link data to each other. Even so, it was fairly similar across both surveys. About 3/4 identified as women. There was a lot of ethnic diversity represented, and most people spoke and understood English very well. About just less than half of our sample were not working at the time of completing the survey, and about 2/3 earned less than $90,000 annually in their household. In the pre-group survey, however, about 36% rated their physical and mental health as either good or better. And in the post-group survey, 45% rated it as such. So then when we kind of dove into what the results of our overall evaluation were telling us, as Geetha mentioned, one of the main domains we looked at was around implementation using the Proctor framework. When we looked at kind of adoption of the video conferencing groups across the hospital, as I mentioned, in our evaluation period, we ran 36 unique groups across 6 care programs. We reached over 3,500 unique patients. Most of them participated in one group during this time, although over 1/4 of our patients participated in more than one group during this just over a year evaluation time period. Then we looked at feasibility of participating in running video conferencing groups. Our sample was pretty technologically proficient. And when we asked about kind of barriers to participation, the most common ones that were reported from the patient side were around internet connection. You know, sometimes it can be glitchy at home, or, you know, audio video can drop a little bit because of internet connection. And for providers, the biggest barrier was having the appropriate clinical space to facilitate their group out of. For some providers, they just need a screen and a desk and somewhere to sit. Other providers do need a clinical space that allows them to demonstrate what exercise or stretching movement based interventions might look like. Another important aspect of feasibility was really demonstrated by this quote from a patient who said, "It was way easier to participate while working from home. I only needed to block off the exact amount of time and not commuting time." So in terms of the feasibility around even just scheduling it into people's days, it worked really well for most people. Patients really felt that video conferencing groups were an acceptable and appropriate way of receiving care. This was echoed by our providers as well. When we look at the results of the satisfaction with therapist and therapy scale that we administered, our results in satisfaction with a video conferencing therapy group are actually very similar to what we see in the literature for in-person group interventions. And this patient who responded to our survey said, "Asking questions and hearing from others allows for a more personal experience and increases one's own knowledge," which, if you think about it, is what someone might say for an in-person group or a virtual one alike. Finally, related to implementation, in this evaluation, we looked at the sustainability of video conferencing groups at Women's. And most facilitators said that they were happy to have the option of facilitating a video conferencing group in the future, but were a bit mixed as to whether they would actually choose a video conferencing group over an in-person one. In the future, patients said that they would prefer a video conferencing group or a combination group over an in-person or hybrid group. For the purposes of our evaluation, a combination group was defined as one where some sessions are in person and some sessions are virtual, but everyone is all in person or all virtual together at the same time. Next, we asked patients about what their interaction was like in a video conferencing format, and patients and providers alike felt that it was pretty easy to interact with other group members online. Concerns that were vocalized related to virtual etiquette, things like, where do I where do I position my webcam? Should I look directly into the webcam or should I look at the boxes on the screen? And people did, talk about the loss of these kinds of casual in-person interactions. But for the majority of people who responded to our survey, the benefits in terms of convenience really outweighed the drawbacks. As one patient said, I thoroughly enjoyed each week and feel that I benefited greatly from each session. I would have liked to engage further with other group members, but I understand why that wasn't possible. I felt a renewed sense of self since completing the course and will continue to grow and develop the new skills, thoughts, and behaviors I learned. The next big domain that we looked at was around quality. Safety concerns didn't really come up for our patients while participating in the group. Any concerns that people had about confidentiality was related to them being able to find a space at home where no one else would hear. People didn't really report on feeling like their confidentiality was jeopardized through actions of other group members on the other side of the screen. Most facilitators felt that the quality of care they could provide was similar to that of an in-person group. And importantly, almost 80% of patients felt that participating in a video conferencing group made their health issue at least somewhat better. That's a huge number of people feeling like it was helpful to some degree. Patients also very strongly felt that the video conferencing group saved them time and money, and facilitators had kind of roughly the same time and effort expense of running a video conferencing group. This patient really summarized well a lot of the feedback we got around some of the value around participating in a video conferencing group. They said, I'm able to save on time and money. Otherwise, I would have to find a way to get to downtown Toronto from a suburb via bus, subway, walking, and have funds towards it. And I have more access by doing it from home because it's easier to get childcare support by asking relatives to look after kids. So from a financial perspective, from a time perspective, from a caregiving perspective, from a scheduling perspective, these were all major benefits that our patients reported. One of the, I think, really interesting outcomes was around equity and patient-centeredness of video conferencing groups. And as Geetha mentioned, hypothetically, video conferencing groups have benefits for people with invisible and visible disabilities, and this really came out in our evaluation. As one person said, I hope that future therapeutic services will be available in a virtual form going forward. Because I have a mobility-related disability, it is crucial for me to have access to services even when my mobility is restricted by my condition. I'm so happy I was able to receive the help from this group on days when leaving the house would be impossible. Another person said, I saved time, money, lengthy commute, wear and tear on my body, which meant less pain and general stress. I was also able to participate 100% of the time. I may not have been able to participate fully or at all had I needed to do it in person, especially if the group took place in the morning. Pain and fatigue are worse for me in the morning. Lastly, we asked about, overall experience. How would you rate your experience with a video conferencing group out of 10? And both facilitators and patients rated it very highly, 8.5 and 8.4 out of 10. As one patient said, overall, I was extremely pleased with the care and support I received. The facilitators did an incredible job at bringing the group together and for us to focus on topics we wanted to bring forward. Thank you for such an amazing experience. It's really helped me move into a place of grounding and understanding my needs better. So to kind of summarize our overall evaluation here at Women's, we implemented and evaluated this innovative ambulatory model of virtual care alongside a very theory-driven evaluation framework. Through this evaluation across the hospital, across multiple care programs, across different types of group interventions, whether it be therapy, exercise, education, we learned that video conferencing groups allowed patients to have flexible access to care. Although we didn't formally assess clinical outcomes, patients felt that their participation improved their well-being, and patients and providers all had a good overall experience. Of course, with any evaluation and implementation, there's always limitations to discuss. Women's College is really innovation forward and was already familiar with video-based clinical visits. So when we think about how this might apply to other centers, it may not be sort of broadly applicable to centers where virtual care is not isn't as part of the center of how care is delivered. In addition, our virtual group evaluation framework is new. It's something that we put together, and so we need to continue to use it in practice in order to validate its utility and generalizability to multiple types of settings. And limitations specific to our evaluation include those related to data linkage. We weren't able to link the pre and post group surveys to each other, nor to EMR data. So we weren't able to assess change in outcomes or progress. And we weren't able to assess clinical outcomes for this evaluation because of the wide variety and structure and format of the groups that were offered across the hospital. We also use different time periods for each data source for very pragmatic reasons, and so that limits their comparability to each other. We also had a low response rate for our post-group survey of around 15%, which introduces potential bias around who was more likely to complete those post-group surveys. And finally, we were unable to compare our outcomes to those of in-person groups, as at the time where we were planning and running our evaluation, Women's had not yet very widely reintroduced in-person group interventions. However, this work, even with these limitations, this work really gives us a lot of answers about things and raises a lot of future questions that we hope to work to answer, including around clinical outcomes of care delivered virtually, how you determine which patients benefit most from a virtual group versus an in-person one, so that we can really tailor how we deliver care to who will best receive it in that way. And how we design, hybrid models and systems of care that incorporate both in-person and virtual programming with patient choice at the center of what we deliver. With that, I'm going to turn it back to Geetha.
Next slide.
Yeah.
So as you can see, as we put together this presentation, we realized the massive amount of work that was done, and both from an implementation and from an evaluation, and some key lessons learned. And through this process, the first lesson that we learned was when you engage multiple stakeholders around the same vision, innovation can occur rapidly. We launched group-based video visits 2 months into the pandemic across multiple different programs, across multiple disciplines, working together alongside IT, administrative and clerical personnel, and clinical personnel. So we just need to have the same vision and the mindset, and innovation can happen fast. Lesson number 2 that we learned was that when you're trying to rapidly innovate and implement programs, the traditional model is that evaluation may slow things down. So let's not evaluate, let's implement and then consider evaluation. But this was not the case here. We did a pragmatic evaluation alongside implementation and embedded the processes as we implemented to really support continuous quality improvement efforts and evaluation. And then lesson number 3 is that, the culture of institution around supporting innovation really matters. We use the principle of progress over perfection, where we were able to develop and implement our first video conferencing group within 2 months of the onset of the pandemic, despite the massive nature of this undertaking. Then during the implementation process, stakeholders were open to iterative improvements in between each phase, learning from the implementation in order to work towards getting it right. And we really need to embed systems to support this culture. Next slide. And then how do we tie it all into the learning health system that we're developing here at the hospital? So the rapid development and iterative implementation of group video visits here at Women's College Hospital really demonstrated the principles of a learning health system at the heart. We transform data to knowledge, knowledge to practice, and practice data back to data in a circular fashion. And we embedded continuing evaluation alongside iterative ongoing improvement opportunities as well. Next slide. And it really ties really nicely with the Women's 2030 strategic direction, where we're leading the new era of sex and gender. By offering group-based video visits, we circumvent issues with regards to childcare, moving the needle on health equity by supporting patients that live far away for access in innovative care redesign. And we're really imagining how health systems can support our patients through innovative ambulatory care models. Next slide. And so Women's College Innovation to securely and sustainably support video conferencing group really shows that we can reimagine how healthcare services are delivered and use this to address issues of equity. And moreover, we were able to do it across multiple different care programs across disciplines, not just within one clinical area of the hospital and scale. We actually spread it across multiple hospitals and we implemented it, and that's really, really innovation at the core. Next slide. So we wanted to really get, the feedback of this group. How can we leverage this work and these findings for the future of care at Women's College Hospital as we think towards learning health systems? And so if you can join slido.com and enter 3627206, really a poll where we want to encourage everyone on this call to participate and share your thoughts on how best we can do this. So as I'm reviewing, people are still typing away, but it sounds like people are interested in scaling across other areas that have not yet done group video visits, implementing it and supporting programs that haven't tried it yet, really ensuring we address barriers to equity and understand those who decline video groups, what are the reasons, and seeing if we can address these reasons. How do we continue to improve the delivery of virtual groups based on the evaluation metrics to date to support the continuous quality improvement efforts? I'm also seeing ensuring academic partnering with patients, scaling it in primary care. Some have noted barriers that it can be clunky, so seeing how we can, address those technical barriers as well. Interprofessional partnerships as well across the hospital. I mean, one of the benefits of this work to date is that group-based subcommittee consisted of with interprofessional participation across all the disciplines and clinical areas that participated in group-based video visits. So that really allowed us that unique opportunity to share learnings, but also to ensure we're addressing barriers for facilitators and patients in a systematic way across multiple clinical areas. One of the benefits is because we implemented technically very similarly across different areas, it allowed us to learn from each other because we were doing similar types of implementation. Oh, I like this, something exposing techniques to learners. So how do we empower learners to participate and facilitate group-based video visits? And maybe there's some opportunity from an academic perspective to do research in that space. So those of you on the call who are interested in that educational academic space, that does provide a unique opportunity. How do we standardize this and scale? Some people say that they love this, which is great. Attitudes involve trainees. So lots here, and it looks like there's interest in spreading and scaling and evaluating and supporting the culture of continuous quality improvement and thinking through how do we empower, embed other programs, but also trainees, and to ensure some consistency and some self-efficacy in delivering group-based video visits. And once again, we do need to understand barriers to participation. We haven't got it quite right yet. We've addressed some of the barriers, but we need to unpack and understand why people don't participate. We also need to better understand the impact on clinical outcomes across the different areas and do far more research to unpack that. Next slide. So future questions for the Learning Health system. We did implement or embed surveys within My Health Record, but there were some limitations from doing that, and also in terms of the robust ability to do that with high response rates. So how do we design feedback loops to ensure we integrate real-time learnings from evaluation on an ongoing basis? How do we scale and spread? How can our institutions support others in expanding this type of care? And that came up with the Slido as well. I'm thinking through how do we spread and scale across some programs that could benefit, because you can have this reach. We show that there's some improvements in quality, and patients seem to like that opportunity of learning from their peers and having that group-based discussion. So can there be opportunities for others who want to implement it? And that's part of the reason we wanted to share the data, not only for the groups that are actively participating, but can we kind of hopefully spread it to other areas as we think about the value proposition of group-based video visits. So next slide. So we really wanted to thank Dr. Lori Wasserman, who was a chair, and all the members of the group video visit subcommittee. Was very integral to reviewing some of the surveys, ensuring the implementation and continuous quality improvement efforts were done. The IMIT staff who supported this work at every stage of the way, providers who participated in the evaluation and operationalizing the video conferencing group on the ground, and also our persons with lived experience who reviewed our surveys, who were involved and who provided some helpful feedback for us to improve the delivery of the care, and also senior leadership for support. And I also wanted to thank Neesha, who pivoted her PhD project and decided to take this on, and she's done such a wonderful job and continues to be involved and interested in supporting the learning health system and looking at group video visit here. And we're thrilled to have her as a postdoc working alongside Simone Vigode in mental health in this space. So next slide, we wanted to open it up for discussion and wanted to have time for discussion for group video visits. So thank you.
That's great. Thanks both so much. It's really amazing work, and so interesting to see what's happening in the hospital and how much evaluation, improvement, cycling, and in the manner that we're sort of envisioning for an LHS. So it's really, really gratifying to see this. So we do have time for some questions. And great, okay, we'll start with Nancy.
So I just want to say the clunky comment was mine, and I just wanted to clarify that because actually I don't think the technology is clunky for the most part. And Zoom is great for this. And I know people who are working at other places that are using Teams and things like that, which I think would be a nightmare. So I think overall the technology is not clunky. What I was referring to though is that we actually are doing hybrid visits. I think Sue and I might be the only, Sue McCray and I might be the only people that are doing, in trauma therapy, we have two kinds of hybrid programs. So we have our day treatment program where we do 3 days a week virtual and 1 day a week in person for the whole group together. But then Sue and I are also doing a longer term group where there's 9 people in the group, and we've been going back to doing more in person. We do in person about once a month with that group, and sometimes not everybody can make it. So we've been using the meeting owl for that. Which is okay, like it works. It's better than not having everybody there. The technology that's in the like super ramped up rooms that do hybrid meetings doesn't have access to Epic at this point. So we can't do hybrid groups in those rooms, but I would put in a plug for that. If we're going to move in the direction of hybrid groups, that I think there is better tech than we have now. But they definitely work. Yeah, in trauma therapy, I would say one of the big benefits has been, I think we've increased our overall program capacity because prior to the pandemic, one of our main limitations was room space, both the number of people that you can fit in a room and the number of rooms that we have. So definitely it increased our program capacity, like not enough. We're using other strategies to do that too. But that's definitely made a big difference just in terms of like we offer 30 to 40 groups a week on average. And we could never have done that without virtual.
Thanks, Nancy. That's really, really helpful feedback. And one of the things, to mention is that group video visit doesn't replace in-person visits. It allows for an option for patients. And there's clearly an important consideration that one, that it allows for more of a reach. It's cost effective, and it supports some of the capacity constraints so we can reach more people. But there's still a role for the in-person in-person visits for group-based health interventions. And it's also providing that flexible space and also the opportunity for patients to select what they want to do. And so that option is really essential as we think about hybrid modalities of care at the hospital. We also need to be thinking about who benefits from what types of care modality and what's the best mix of hybrid care in person and group, and evaluating that and ensuring our technology supports. If we're trying to do hybrid modalities of care, how do we ensure that the quality, if we're doing hybrid at the same time synchronously, the quality for both the people at the in-person is equal to those at home? And so thinking about that as well is an important space as we build upon this work for the future. So thank you. I see a couple of hands are up. I'm going to have Dave.
I see Salmia next. Salmia, we can't hear you. You're still on mute.
So sorry. Thanks, David. Thank you so much, Geetha and Neesha, for this talk. It's such a great way to kick off the brand new season of LHS seminars. And I especially appreciated the interactive aspect that you brought into this. I think it was the first LHS seminar we had with a live poll, and I think that's really fun. And I apologize for missing the first part of your talk. I had to give a presentation. I may have missed this, but I really liked how you described one of the lessons being, you know, you really need to rally multiple stakeholders around the same vision, and only then can that enable, you know, rapid change. I was just curious about your approach with bringing all the stakeholders onto the same page, and like, how did you approach, and was there a certain sequence you followed? So yeah, that would be great to know.
So the pandemic really accelerated some of this because there was a burning platform. There was a need to meet continuity of care. And so that accelerated the need, the premise of meeting continuity of care really supported that. So in terms of the context that this was implemented, that alongside ensuring both IT, administrative personnel, clinical personnel across multiple disciplines were engaged in doing group video visits. We needed to ensure that technology meted the needs of the clinical programs, but also meeting the needs as the security considerations as we're pivoting to a novel modality or novel form of innovation. So one of the things that was done was having that group video visit subcommittee. And I think that was very integral in this process because we got the players together at the same table in a condition agnostic way. So we had people from mental health and cardiac rehab and pain were all together alongside, you know, implementation and IT, and so that we could understand what are the challenges as we did the rapid scale rollout of all of this. And people, and because there was some pilot precedent, so it wasn't that group video visits never existed before this. It was done in a pilot way. It was done in very treatment specific ways, rather than like across a hospital looking at in a condition agnostic implementation. So we did have some precedents, but we didn't have obviously this new way of doing it across the hospital, which was really spurred by the pandemic. So I think a combination of the right context alongside engaged people all wanting the same things of continuity of care really supported this. And then people wanted to evaluate. And we also had the Women's Virtual Initiative was launched 2019, right before the pandemic. So it was the right context for evaluation as well. So, you know, when we propose things like looking at, you know, surveys and having people review that, people weren't, there weren't any barriers in some ways. And also wanted to thank the IT team because, you know, this was a huge IT endeavor and we have a great team. And I'm not just saying it because I'm the CMIO here, but I really think our IT team was really supportive and very thankful to be working alongside them and supporting some of this work.
Thank you.
We have time for a couple more questions, I think. Natasha?
Thanks, David. Thanks, Neesha and Geetha. What I'm blown away about is the data. So even though, Neesha, you said we had a low response rate at the end, still the absolute numbers were pretty impressive, right?
Mm-hmm.
And what that kind of shows me is that when you have the institution backing you, you know, you get some really amazing data, right? So that's kind of the first thing of like, you know, these initiatives get off the ground because the institution is behind it. Otherwise, people are kind of lifting it up on their own. And then I struggle with projects that have kind of been born in the pandemic because, you know, people use the word burning platform. Absolutely. We were stuck, right? And everybody had a collective vision. And so, you know, projects that are successful like this during the pandemic kind of make sense to me because we had a trapped audience of willing individuals who needed to pivot in some way. So, and I'm sure you guys are doing this. I'm actually curious to know what the data would show now about patient likability with video visits. I'll tell you, most of my patients want to come in person for my visits, even though I frequently offer them, hey, I can see you by video next time. Majority of my patients are saying, you know what, I'd rather come and see you in person. And so for a person like me who is in two departments who do no video visits, that would be helpful for me to know, like, how was it between 2022 and 2024? What was the feedback about video visits, both from providers and patients? But really great work, guys. It's really impressive.
Thank you. I think that that's such an important point, right? Especially when you talk about a learning health system. It's not that you do one evaluation and you leave it. We need to be almost repeating this on a regular basis to know how the perspective of the institution, the providers, and the patients evolve over time. I think one thing that has that kind of got brought out by this work, and my bigger PhD work was around evaluating a specific group for postpartum people. And I think one thing that's really coming out is people with kind of enhanced barriers to care, whether it's, you're postpartum, you don't know if you're going to have slept at night, the challenge of getting an infant downtown to the hospital, all of those things, whether you have a mobility concern or some sort of other ability limitations to get you in person. I think one of our next tasks needs to be, as an institution, figuring out who does this work best for, because I'm not a believer that virtual is the correct solution for everyone at every point in time, right? I don't think any of us really are, but I think understanding, yes, when you have a captive audience, it works for everyone. When you don't have a captive audience, it still works for people. And so figuring out who it works best for is, I think, an important next step of this work.
And I think we have time for one more quick question and quick response. Chandra?
So my question dovetails really nicely with this conversation. First off, I really like the alignment of the design to the clinical workflow. That was amazing. And I know this is group video visits, but looking at the organization, current level of virtual visits has decreased since the pandemic, response. And so, I guess the question is that really where it would lie typically in terms of where the mix should be between in-person and virtual? Or really, do we understand what's driving that? Is that the patient request? Is that the provider experience? And is there an opportunity with the LHS to really evaluate meeting the needs of our patients and our providers to deliver the best care and monitoring those utilization of virtual care?
No, that's a really good point, Chandra. And I think what you've highlighted is that, like, we're now like this post-pandemic phase. There's a variability in adoption of virtual video visits across the hospital. Like in some areas where you need an in-person exam, like for example, AACU's almost very little video visits. And then there's other programs like mental health. There still has a reasonable level of adoption, although it has come down since the pandemic. And I think it's a combination of factors, providers, and sometimes I offer in person. And today I had 2 cancellations for video because 2 of my patients think they have COVID or URTI or their child is sick. And so sometimes this pivots. And I think even seasonally it pivots for patients. And, so I think that the mix of in-person and virtual care will continue to be variable across our different programs, but really unpacking what are the driving forces. Is it a provider? Is it a patient? Is it a shared decision-making based on the next visit, what makes sense? And sometimes the shared decision-making also pivots and people call and say they want to come in person, or then they call and say, no, can we switch to video? And I think understanding, going back to Neesha's point, who benefits and for what cases, and what are the equity considerations, and understanding who it benefits for is still required. We know it can be done. The question is, what is the quality and outcomes, and understanding how do we best design systems to ensure hybrid modalities of care meet equal quality for patients. And I think we still have those answers, which is a very ripe area for people who want to go in this space, and hoping Neesha will build this for her career as we, engage in our learning health system here, and hopefully we can support this ongoing culture of continuous quality improvement and evaluation as we think through how do we design hybrid modalities of care.
So that's great. I'm unfortunately, we are at time and we don't have any more time for questions. I apologize to those of you who did have additional questions. I just want to once again thank Neesha and Geetha so much for all your work and for presenting it. Great discussion and great role modeling, I think, for what the potential is at women. So thanks so much to you both. Thanks for everybody. And also, if you can just do the QR code here, scan and go, which will take you to the link for a quick evaluation. So thanks so much, everybody, and have a wonderful day.
Thanks so much, everyone.
Thank you. Thank you.